Hello, today we are going to study arthritis in a structured clinical manner. Arthritis is often misunderstood as simple joint pain. However, clinically, it represents a spectrum of pathological processes involving inflammation, degeneration, immune dysregulation, metabolic disturbance, and systemic constitutional factors. Before discussing treatment, it is essential to classify arthritis correctly. Management depends entirely on identifying whether the pathology is mechanical, autoimmune, metabolic, or inflammatory. This lecture will bridge conventional rheumatology with homeopathic understanding. Now we will see the definition of arthritis. According to Harrison's principles of internal medicine, arthritis refers to inflammation of joints. However, in clinical practice, the term also includes degenerative disorders such as osteoarthritis. We must distinguish between arthralgia, which is joint pain without inflammation, and arthritis, which is joint inflammation with swelling, stiffness, or structural change. This distinction prevents misdiagnosis and inappropriate treatment. To understand the arthritis, we must first understand the normal joint anatomy. A synovial joint consists of articular cartilage, synovial membrane, joint capsule, synovial fluid, and subchondral bone. Cartilage is avascular and receives nutrition through diffusion. That is why cartilage damage heals poorly. Inflammation of the synovial membrane plays a key role in autoimmune arthritis. Now we will see the pathophysiological mechanism as described in Robin's pathologic basis of disease. Arthritis develops through three main mechanisms: degenerative, autoimmune, and metabolic. Degenerative means cartilage matrix breakdown. Autoimmune means immune mediated synovitis. And metabolic means crystal depositions such as uric acid. Each mechanism involves distinct biochemical cascades. For example, autoimmune arthritis involves cytokines like TNF alpha and IL-6. Understanding mechanism guides therapy. Arthritis can be broadly classified into osteoarthritis, rheumatoid arthritis, gout, and seronegative spondyloarthropathies. Each has different age distribution, lab findings, radiological features, and prognosis. Treating all joint pain as one disease is clinically incorrect. Now we will see osteoarthritis, which is a degenerative cartilage disorder. Osteoarthritis is the most common form of arthritis worldwide. It is traditionally described as a wear and tear disease, but modern understanding shows that it is a biochemical degenerative process, not merely mechanical aging. The articular cartilage gradually loses proteoglycans and collagen integrity. Chondrocytes attempt repair, but over time, degradation exceeds regeneration. It is primarily localized and non-systemic. Now we will see osteoarthritis pathogenesis. The pathological sequence begins with cartilage matrix degradation. Loss of proteoglycans reduces shock absorption. Fissures develop in cartilage. Subchondral bone becomes exposed and thickened. The body responds by forming osteophytes, bony projections at joint margins. This explains stiffness and restricted movement in advanced osteoarthritis. Inflammation exists, but it's of a low grade compared to rheumatoid arthritis. Now we will see what are the risk factors. Age increases susceptibility due to the reduced cartilage resilience. Obesity plays a dual role: mechanical load on weight-bearing joints and release of inflammatory adipokines from the adipose tissues. Previous trauma accelerates the cartilage damage. Genetic predisposition influences the collagen structure. Importantly, not every elderly person develops the symptomatic osteoarthritis, indicating the multifactorial causation. Now we will see the clinical features of osteoarthritis. The hallmark of osteoarthritis is mechanical pain. Pain worsens with activity and improves with rest. Morning stiffness usually lasts less than 30 minutes. Crepitus, a grinding sensation, suggests cartilage erosion. Joint swelling, if present, is mild and non-inflammatory. Commonly affected joints are knee, hips, cervical and lumbar spine, DIP joints. Heberden's notes. Okay. Now what we will see on radiological investigation reports in case of osteoarthritis. X-ray findings include asymmetric joint space narrowing, osteophyte formation, subchondral sclerosis, and subchondral cysts. However, radiological severity does not always correlate with the pain severity. Clinical assessment must guide the management, not imaging alone. Now, after osteoarthritis, we will see rheumatoid arthritis. Rheumatoid arthritis is a systemic autoimmune disease. Unlike the osteoarthritis, it is inflammatory and progressive. The immune system mistakenly targets the synovial tissue. This leads to chronic synovitis and joint destruction. It commonly affects women more than men and can begin in early adulthood. Now, what is the pathogenesis of rheumatoid arthritis? The pathological cascade begins with autoantibody formation, including rheumatoid factor and anti-CCP antibodies. Immune complexes deposit in synovium, chronic inflammation develops, granulation tissue called as pannus forms. Pannus invades the cartilage and bone. Without treatment, deformity occurs. Cytokines such as TNF alpha and IL-6 drive the inflammation. What are the clinical hallmarks? Rheumatoid arthritis characteristically presents with symmetrical small joint involvement, metacarpopharyngeal and PIP joints commonly affected, morning stiffness lasting more than 1 hour. Patients often describe difficulty opening jar or making a first feast in the morning. Fatigue and low-grade fever may accompany the joint symptoms, which we don't find in osteoarthritis. Now, what are the laboratory markers? Rheumatoid factor is present in many cases, but is not fully specific. Anti-CCP antibodies are more specific and predictive of erosive disease. ESR and CRP indicate the systemic inflammation. However, diagnosis is clinical. Lab tests supports but do not replace the examination. What are the extra-articular features of rheumatoid arthritis? That is also very much important to examine in the patient, because rheumatoid arthritis is not limited to joints. It may involve the rheumatoid nodules under the skin, vasculitis, interstitial lung disease, and anemia of chronic disease. This systemic nature differentiates rheumatoid arthritis sharply from osteoarthritis. Early recognition prevents the irreversible joint damage. Now next comes gout. Gout is a metabolic arthritis caused by the hyperuricemia leading to monosodium urate crystal deposition in joints. It is one of the most painful forms of osteoarthritis. Unlike rheumatoid arthritis, gout is episodic and acute in presentation. It often affects the middle-aged men and is strongly associated with diet, alcohol intake, obesity, renal impairment, and metabolic syndrome. Now we will see the pathophysiology of gout. When the serum uric acid exceeds its solubility threshold, crystals deposit in the joint spaces. These crystals activate the neutrophils and the NLRP3 inflammasome, triggering the intense inflammatory response. The result is sudden swelling, severe pain, redness, and warmth. Importantly, uric acid levels may be normal during an acute attack. Diagnosis should not rely on the lab values alone. What is the clinical pattern of gout? Classic presentation is acute onset of severe pain at night. The first metatarsophalangeal joint, called as podagra, is commonly involved. The joint becomes extremely tender, red, warm, swollen. Patients often cannot tolerate even the bedsheet contact. Chronic untreated gout may lead to tophi formation. Next is ankylosing spondylitis. It is a chronic inflammatory disorder affecting primarily the axial skeleton. It commonly affects the young males. Unlike osteoarthritis, pain improves with movement and worsens with rest. It is strongly associated with HLA-B27 antigen. Inflammation begins in sacroiliac joints. What are the key features? Key clinical clues include the morning stiffness lasting for more than 30 minutes, improvement with exercise, limited chest expansion, chronic back pain beginning before the age 40. Radiologically, sacroiliitis is diagnostic. Untreated cases may develop bamboo spine due to ligament ossification. The differentiation between the osteoarthritis and rheumatoid arthritis is very crucial. In osteoarthritis, there is a mechanical pain, localized. Osteoarthritis is localized and minimal systemic symptoms are there. But in case of rheumatoid arthritis, it's an autoimmune disease often seen or maximum it is seen as a symmetrical ailment and pathological changes, and it is associated with fatigue and systemic features. Morning stiffness duration is a key differentiator between these two. Now, rheumatoid arthritis versus gout. Rheumatoid arthritis is chronic and progressive, whereas gout is acute and episodic. Rheumatoid arthritis involves small joints symmetrically, whereas gout commonly affects one joint at a time. This distinction prevents misdiagnosis and improper long-term management. Inflammatory pains are worse in the morning, improves with the movement, associated stiffness is present. In case of mechanical pain, they worsen with activity, improves with rest, and minimal prolonged stiffness is there. This clinical clue alone can guide early differentiation even before the lab reports. Now, blood investigation. Lab investigations should support the clinical diagnosis. ESR and CRP indicate inflammation. Rheumatoid factor and anti-CCP support the RA diagnosis. Uric acid supports gout, but may be normal during the acute attack. Investigations should be interpreted in clinical context, not in isolation. Now, what are the imaging modalities? X-ray shows structural changes but appears late in disease. MRI detects early synovitis and bone marrow edema. Ultrasound is useful for detecting joint effusion and crystal deposition. Early imaging is suspected Early imaging in suspected rheumatoid arthritis improves the prognosis. Now we will see about the conventional treatment. Management depends upon type of the arthritis. For the symptomatic relief, most commonly the treatment modalities are the NSAIDs, which reduces pain and inflammation. In rheumatoid arthritis, DMARDs such as methotrexate slow disease progression. Biological agent target specific cytokines like TNF alpha. Steroids provide the rapid control but are not ideal long-term solutions. Treatment must balance efficacy with safety. Limitations of pharmacology. While conventional drugs are effective, they have limitations. Long-term NSAID use can cause gastritis, renal impairment, cardiovascular risk. Steroids may cause weight gain, osteoporosis, diabetes. Biologics increase the infection risk. Therefore, monitoring is essential. This opens discussion for integrative approaches. Now we will see about the homeopathic perspective here. From a homeopathic perspective, arthritis is not merely joint pathology. In organon of medicine, disease is described as a dynamic disturbance of the vital force. Joint inflammation represents extreme expression of deeper imbalance. Treatment focuses on constitutional state, modalities, mental and emotional symptoms, general characteristics. This differs fundamentally from suppressive pharmacology. Miasmatic view. Miasmatic understanding adds the depth. Psoric tendency shows functional pain and early inflammatory states. When it moves further to psychotic tendency, it shows overgrowth, thickening, and stiff joints. In syphilitic tendency, there is a destruction, deformity, rapid degeneration. Recognizing miasm helps to predict the progression of the disease. Now, individualization principle. What is this? In homeopathy, two patients with rheumatoid arthritis may require completely different remedies. Remedy selection depends on thermal modalities, mental state, sleep pattern, food cravings, generals. Individualization is the cornerstone. Pathology guides seriousness, constitution guides remedy. Now, following are few common remedies which are commonly taken into consideration with the above pathologies we have discussed. Rustox. Under Rustox, patient is better by movement and worse by initial motion. Next is bryonia. Bryonia is worse by movement, better by rest. and it's of an irritable temperament. In Ledam it's kind of an ascending type of gout and it is better by the cold application. Causticum. Deforming tendencies are present in causticum patients with progressive stiffness. These are the example and not the prescriptions. Now, what should be the integrative approach? First comes the weight management. Even 5 kg weight reduction significantly reduces the knee joint load. Adipose tissue produces inflammatory cytokines. Weight management reduces both mechanical and inflammatory stress. Lifestyle modification is non-negotiable in osteoarthritis. Next comes exercise in case of arthritis. Contrary to belief, rest alone worsens the stiffness. So, patients with osteoarthritis are recommended swimming, cycling, quadriceps strengthening. Avoid high impact jumping activities. Movement nourishes cartilages through the synovial fluid circulation. Now we will see what is the psychological impact. Chronic pain increases the depression risk. Chronic arthritis significantly affects the mental health. Persistent pain alters sleep cycle, mood, social participation. Depression and anxiety worsen the pain perception. Pain is not purely structural, but it is biopsychosocial also. So, due to the psychological impact, the counseling integration naturally comes in these cases. Pain perception is influenced by the emotional stress, catastrophic thinking, fear of movement. But counseling reduces the central sensitization. Integrative management includes education, reassurance, psychological support. Treating only the joint is always incomplete. Now, while diagnosing, examining, and treating these patients with osteoarthritis, we are supposed to keep in mind about the red flags. So, what are these red flags? Certain presentations require urgent medical evaluation, and these red flags include the high fever with joint pain, rapid onset severe swelling, inability to bear the weight, red, extremely tender joint. This may indicate the septic arthritis and it's a medical emergency. Septic arthritis can destroy cartilage within days. Never delay referral in suspected infection. Now we should know referral guidelines also. So in suspected rheumatoid arthritis, early referral to a rheumatologist is critical. Evidence shows that initiating the DMARD therapy within the window of opportunity, usually first 3 to 6 months, significantly reduces the long-term deformity. Delayed diagnosis leads to irreversible joint erosion. As integrative practitioners, recognizing limits of practice is very essential. Now, prognosis. Early diagnosis prevents the deformity. Prognosis depends on what? It depends on type of the arthritis, what is the severity at the diagnosis, timeliness of intervention, and patient compliance. Osteoarthritis progresses slowly. Rheumatoid arthritis may cause deformity if untreated. Ankylosing spondylitis may lead to spinal rigidity. Early recognition changes outcomes dramatically. Accurate diagnosis precedes treatment. This is the key clinical message for us. Not all arthritis is the same. Treating all joint pain with painkillers is irrational. First, determine, is it inflammatory or mechanical? Is it autoimmune? Is it metabolic? Is it infectious? Only after classification should treatment begin. Diagnosis drives management. If you found this academic breakdown helpful, support the channel, like the video, share it with those suffering from joint disorders, subscribe for structured, evidence-based integrative medicine lectures. If you require detailed evaluation for the chronic arthritis, online consultation is available. Proper assessment prevents progression. Thank you.